Good afternoon, everyone, and welcome to our next Safer Prescribing series webinar funded by the Michigan Department of Health and Human Services. Today, we will be discussing benzodiazepines, prescribing, tapering, and polysubstance use. My name is Michael Smith. I'm an associate professor at the University of Michigan College of Pharmacy. And today we have with us two wonderful speakers that you'll hear from shortly. Next slide. There are no financial disclosures for this presentation. Next slide. On the screen, you will see the learning objectives for today's sessions. We will hear from both of our speakers and have time at the end for question and answers. Please put any questions in the Q&A and the Zoom controls at any time during the session. Next slide. We are offering 1.5 AMA PRA Category 1 credits for free for attending the session. You will find information for claiming CME at the end of this session and in the follow-up email that you will receive later today. Next slide. So today we have two speakers. The first is Dr. Alek Adkins. He is an assistant professor of emergency medicine and pediatrics at The Ohio State University. He's currently one of the medical toxicologists with the Central Ohio Poison Center and Nationwide Children's Hospital. He also serves as an attending physician with the Ohio State Wexner Medical Center, Department of Emergency Medicine. Dr. Adkins got his undergraduate degree in biochemistry from High Point University in High Point, North Carolina. He graduated medical school from the Ohio State University College of Medicine and completed his emergency medicine residency at Christiana Care in Newark, Delaware. After residency, he completed his medical toxicology fellowship at UPMC in Pittsburgh, Pennsylvania. He is currently board certified in emergency medicine and medical toxicology. Dr. Adkins' interests include addiction medicine, acute inpatient toxicology, and systems-based delivery methods for antidotal therapy. Our second speaker is Dr. Amy Vandenberg. She is a clinical professor at the University of Michigan College of Pharmacy and clinical pharmacy specialist in psychiatry and neurology at U of M Health. She earned her PharmD degree from the University of Michigan College of Pharmacy and completed her PGY1 and PGY2 psychiatric pharmacy residencies at the Medical University of South Carolina, where she practiced until 2016 before returning to the University of Michigan. She's a board-certified psychiatric pharmacist since 2002 and has extensive experience in psychopharmacology, working with diverse patient populations across inpatient and ambulatory care settings. Her inpatient practice areas at U of M include general adult neurology, adult psychiatry, and consult liaison psychiatry, addictions consult, and psychiatric emergency services. From 2022 to 2025, Dr. Vandenberg collaborated with an interprofessional committee and the American Society of Addiction Medicine to develop the Joint Clinical Practice Guideline on benzodiazepine tapering. I'll hand it over to Dr. Adkins to begin our presentation.
Awesome. Thank you, Michael, for the introduction. So first off, Praza, Loraza, Diazepam, what? Let's talk about some introduction to benzodiazepines. Next slide. So first, we got to talk about what is a benzodiazepine. And overall, they belong to this class of medication called sedative hypnotics. And as you can apply, what they do is they cause you to sleep and cause your CNS to go down. And how this works is that these benzodiazepines interact with the GABA receptor, allow it to open more frequently. It actually decreases neurotransmission. And this overall is going to lead to your CNS depression, your sedation, and your anxiolysis. Next slide, please. So let's actually talk about what are some common benzodiazepines you may come across in the outpatient setting. And the first up on the list here is alprazolam. I'm sure many people here have some love-hate mixed feelings about this medication. Its main use today is predominantly going to be for anxiety. It has a very rapid onset of action with its peak effects somewhere in about 1 to 2 hours. And it has a very, very short duration of action compared to our other medications. It lasts somewhere between 1 to 12 hours, more on the 1 to 2 few hours. But some people who are slow metabolizers, it can last in their system for a while. And because of this rapid onset, rapid offset, this medication is a pretty darn high risk for dependence and addiction. Next slide, please. Next up our list here is everyone's favorite, probably workhorse, lorazepam. What is it used for? Just about everything for benzodiazepine. We use it for seizures, alcohol withdrawal, vertigo, anxiety, catatonia. If a benzo can fix it, chances are lorazepam is one of those benzodiazepines. Its initial sedating effects take place somewhere between 20 to 30 minutes. And like many of the other PO medications, it's going to peak around 2 hours for your maximal sedating effects. It is classified as a short to intermediate benzodiazepine with about a half-life and onset about 12-ish hours, give or take. And one of the unique features that you may have learned about in medical school or nursing school is that this is classically labeled as safer for patients with liver dysfunction because so much more of this medication can be excreted in the urine as the parent compound, and it doesn't always have to undergo hepatic metabolism. Next slide. Now, this is my personal favorite benzodiazepine. This is diazepam. I like it for a few different reasons. One, it has a pretty fast onset, whether you give it orally or IV, about 15 minutes to its peak effect, even in the oral setting, which is really nice. It's also long acting too, which is great for a lot of the conditions that I treat. It has a half-life about 48 hours. And part of that is because not only is diazepam a benzodiazepine, but its metabolites, tenazepam and oxazepam, are also active benzodiazepines as well. And I do want to put this out here that this is still generally safe with patients with liver disease. There is no black box warning that you need to adjust this medication in patients with liver dysfunction. Now, obviously, like this medication, like any medication you give, if the patient does have like active liver failure or active liver injury, you do need to be cautious and judicious. But again, these patients are probably going to be in the inpatient setting and not outpatient when you're if you're dealing with acute liver injury. Next slide. And then finally, one of the more common oral benzodiazepines that we may see or come across in your setting is chlorhydroxyperoxide. I know it's a hard kind of mouthful to say. It's probably one of the trickier ones for even for myself. And realistically, we really only see this in alcohol withdrawal. Now, you can still see this medication sometimes used for anxiety, but its mainstay is predominantly going to be for alcohol withdrawal. It does have an onset of action and peak somewhere around that 30 minutes to 2 hours. We're probably more along the 2 hour mark. This is a very long acting medication with a half-life of somewhere between 24 to 48 hours, similar to the diazepam, but its onset is going to be a lot longer. And because of that, one of the biggest risks that we see with chlorhydroxyperoxide, and especially in recent literature, is that concerns with dose stacking, especially since many people are not really getting those peak effects until closer to that 2 hour mark, that we're seeing people take more and more medicine. And then all of a sudden, we're getting a compounding effect 2 or 3 hours later with oversedation. Next slide, please. So, now we talked about what benzos are and what are some common ones. Next thing on our list here is, can a benzo fix that? So let's take a look at some of our indications. Next slide. Here's just kind of a handful of acute indications that you may have seen for benzodiazepines, whether it be alcohol withdrawal, acute agitation, anxiety, hyperthermic encephalopathies. That's just a really fancy way of saying things like serotonin syndrome, antimuscarinic syndrome, NMS. We also see it in seizures and vertigo. And like pneumotoxicologists, we love benzos and we love bicarb, so you had to give it because I said so. Next slide. But realistically, as a primary care provider, these are probably things you're most likely going to see when it comes to benzodiazepine prescriptions: alcohol withdrawal, anxiety, and vertigo. Next slide, please. There are some chronic indications. Probably the two main ones are going to be epilepsy, so things like clozapam, and kind of long-term persistent catatonia. Next slide. Are there any other more chronic indications? No. And as we talk about later here in the slide, that we probably should not be using it long-term for anxiety, which is why I put this little tongue-in-cheek meme up here for us. Next slide, please. So let's talk about some of the acute options that we have here. The first one on the list is going to be alcohol withdrawal. Now, it typically takes 2 weeks of daily drinking in order to develop and prime the brain to have withdrawal. If it's less than that, the chances of them developing physiologically dangerous withdrawal are pretty low. And unfortunately, really the only predictor of someone who's going to develop alcohol withdrawal is if they've had prior alcohol withdrawal. And most alcohol withdrawal from a physiological standpoint is going to peak in the first 72 hours and will typically last about 5 or 6 days. After that time frame, your patients still might not feel their best. They're still going to have cravings. They may still have some mood disturbances, but the deadly part of withdrawal is predominantly going to be over at that point in time. Next slide. So acute alcohol withdrawal, it can be treated as an outpatient. It can be treated as an inpatient. And when we're treating it as an outpatient, these really are going to be your Goldilocks patients. This is reserved for mild alcohol use and mild alcohol withdrawal only. And what do I mean by that? I mean someone who has never had a history of seizures, hallucinations, or delirium tremens. A lot of times patients don't understand what delirium tremens means, so I usually ask like, "Hey, if you ever stop drinking, do you ever have to go to the hospital and have several days missing, or you wound up in the ICU and you didn't know that you were there for several days?" That's probably a better way to ask if they've ever had delirium tremens, because that really just means alcohol withdrawal with confusion. And besides from not having these prior risk factors from prior alcohol withdrawal times, the other big thing is that the patient really needs to be well appearing and hemodynamically stable. They can have a little bit of tremors that easily go away, but otherwise they should be otherwise well appearing. And they're not that. This patient may not be the best option for an outpatient home detox. The other sort of big things is that the patient has to be trusted. They're not going to drink while they're doing their detox at home, or we really don't want them mixing their alcohol and their benzodiazepines. And then also the patient has to have appropriate health literacy to be able to give themselves the benzodiazepines as prescribed. Because I mean, show of hands here, how many people have tried to prescribe medication more than twice a day, and patients find it challenging. And as we talk about here on the next slide, is that we're going to be dealing with it's a little bit more than just twice a day dosing. Go ahead and advance, please. So, what are you going to prescribe them? My go-to are going to be diazepam or chlorodiazepine epoxide. I like to give somewhere between 5 to 10 milligrams every 6 hours as needed for diazepam, or about 25 to 50 milligrams of chlorodiazepine epoxide as needed every 6 hours. I am personally a bigger fan of symptom triggered therapy over a standard therapy and tapering because it usually allows for overall less medications and less sedation. And anecdotally, I feel like patients have a grasp, a better understanding of taking the medicine when I feel bad, with that PRN sort of mentality. When you think about when they take Tylenol or Motrin, or acetaminophen or ibuprofen or albuterol inhalers, they do get that understanding of that PRN dosing. And I typically will only give them 1 or 2 days. Now, some places and some institutions will give multiple days worth all at once. I personally don't like that because if you are requiring more than 2 days worth, they're probably not a low risk, mild alcohol withdrawal patient, and they really, really should be more closely monitored and at the very minimum, a detox facility or in the hospital setting. And then once they go on that, they take those medications, maybe they come in on Thursday or Friday, really should be following up with them within a week. So they start their detox program on Friday or Saturday, follow up with them by Tuesday, Wednesday, Thursday in the clinic, see how they're doing, see how their symptoms have been. Did they relapse? How are they doing with their cravings? How are they doing with their mood now that they're not using alcohol? And then also, once we're kind of over this acute alcohol withdrawal phase, come up with a game plan to help maintain chronic sobriety. And that usually involves some sort of rehabilitation program, whether it be one-on-one counseling, group therapy, AA meetings. They do need some sort of long-term mental health to help maintain that sobriety. Next slide. Up next, a pretty common indication that we hear or see a lot is going to be for anxiety. And I get it. Benzodiazepines, they work really well for rapidly controlling your anxiety. But this is not a medication that really should be used long term. These medications are pretty good at helping sort of those acute phases as we are titrating up to the full effect of a more better responsive medication like an SSRI, SNRI, antidepressant. And as they're building up to that full therapeutic effect, having a rescue medication to help with that extra panic or that extra depression may be beneficial. However, if you're going to choose to do this, you really need to set clear boundaries as to when you're going to take it, when you're not going to take it, when you're no longer going to prescribe this medication, and what are some potential consequences if you misuse this medication. I know personally at my institution, we put patients on benzodiazepines. They have to sign a patient contract with us. That goes over what they very clear boundaries, what they will and will not do. Next slide, please. And then finally, something you may see it prescribed for more kind of commonly in an outpatient setting is for vertigo. And so low dose diazepam and lorazepam have been used to help with vertigo symptoms. Interestingly, though, there was I guess, recent-ish now article from JAMA Neurology in 2022 that they looked at a systematic review, sorry, and found that antihistamines are actually maybe superior for symptom control in most patients. So things like meclizine may be a better option, and probably for the most part are going to be safer in many of our patients. Now, obviously, sometimes our patients are on multiple medications that have varying amounts of antimuscarinic effects. Maybe they're on hydroxyzine and olanzapine and oxybutynin for their bladder spasms and mood disorders, and adding on an additional antihistamine may not be the safest option for that patient, and a benzodiazepine may be safer. So it's always something you got to weigh the risks and the benefits. But probably I would say your first choice probably should be more of an antihistamine than a benzodiazepine. Next slide. All right, so now we talked about some of the indications, what they do. Benzodiazepines, what the heck could go wrong? Next slide. All right, we have our first poll up today. True or false, oral benzodiazepines cause respiratory depression? I will give you all maybe 30 seconds here to kind of lock in some votes. All right, that's probably enough time there. Let's go on to our next slide. And we have a second poll here. I should taper my patients benzodiazepines before starting them on methadone or buprenorphine for opioid disorder. True or false? I'll give you all in about 30 seconds. And all right, awesome. Let's go ahead and close that poll. Go on to the next slide. So these are some really potential complications. I think we are relatively familiar with the dependency and the withdrawal and the addiction of benzodiazepines. I want to spend really kind of more the next slide, please. Really focusing here on sort of the CNS depression and the polypharmacy effects of benzodiazepines. Next slide. So first, CNS depression. In and of themselves, oral benzodiazepines are not going to stop your respiratory rate on their own. And a lot of times when I'm teaching this to my students, residents, fellows, medical students, I like to describe the overdose of benzodiazepines as the sleeping beauty syndrome. They are asleep, they look obtunded to the world, more or less, but their vital signs are beautifully normal, and they actually usually do a pretty good job at protecting their own airway. And realistically, what's more likely to happen is that yes, they do cause CNS depression, which is going to lead to increased falls. It's going to lead to decreased coordination and a decreased executive function. And so you should be mindful and educating your patients that, hey, please don't drive, please don't operate machinery, be careful when you get up. Maybe don't go shopping on Amazon or other retailers at 2 o'clock in the morning after you've taken a nighttime dose of a benzodiazepine. That's maybe not the best. Um, but they don't cause a whole lot else by themselves. Now, if you mix them with other CNS suppressants, then that's when you start really getting into the risk of a decreased gag and cough, which is going to increase your aspiration risk. It can also lead to, at that point in time, a decreased upper airway tone. And so, for better or worse, you get a lot of soft tissue obstruction, and it looks very similar to an obstructive sleep apnea. Although, technically speaking, they do not control the actual respiratory center in your brain, and it will not, or should not cause your respiratory rate to go down. Next slide. The next thing we need to talk about is the polypharmacy with benzodiazepines. So this is a CNS suppressant. That's the whole point. It's a sedative hypnotic. And when it's mixed with other sedative medications, you can get an added effect of their CNS suppression from multiple medications. So always please perform a medication interaction check. Check your PDMP to make sure they're not getting other controlled substances. And make sure if you don't have a checker that you're prescribed to, that you can run a quick check. Always call a pharmacist where you're sending that medication to. Many pharmacists or even poison control centers, we can help with that as well. Are more than happy to help looking at medication interactions to make sure that it's a safe prescribing practice. If you are worried about it, really try to consider spacing out your medications by 2 to 4 hours, because that's when most of the onset and peaks are going to happen for many of your medications. And if you're not having the CNS depression by that hour 2 to 4, you're probably safe to take that other medication. And then also counsel these patients on the potential side effects, document them in your chart that you talk about these potential side effects, and then make sure you print them off in clear and simple, easy to understand language in the patient's after visit summaries. So there's multiple ways for the patient to have understanding of what could happen with this polypharmacy interaction. Next slide, please. Now, let's take a look here at what the CDC has said. This is recommendation 11 from the 2022 opiate prescribing practices. This is what kind of became the inspiration behind this talk today. And it states that clinicians should use particular caution when prescribing opioid pain medication and benzodiazepines concurrently and consider whether benefits outweigh risk of concurrent prescribing of opioids and other central nervous system depressants. Kind of a mouthful. Really, they're saying is like, you can do it, but make sure we are doing it carefully and safely. Next slide. So, what happens when you co-administer with opioids? This really is sort of the art of medicine. There are risks and benefits for everything we do. And sometimes it is appropriate that a patient needs to be on both of these medications. And when they are on multiple sedative medications, or really anytime you prescribe an opioid, I think it's really good best practice to always offer the patient a prescription for naloxone and educate them and their family on how to use it. Next slide. So one area that you may see the mix of benzos and opioids is in the acute pain setting. So this is maybe a patient who's on chronic benzodiazepines for better or worse, and they have an event like they broke their back, they broke their arm, and now they need opioids to help with that pain control. That's an appropriate utilization of opioid management, a broken bone. And so you really should be using the lowest effective dose possible. And this is really where you should be trying your best to take a multimodal approach. So consider nerve blocks, consider Tylenol, ibuprofen, or other NSAIDs, lidocaine creams, patches, other salves that can help that you can be placed topically to help with the pain. And then I always like to put this in here. Tramadol still counts as an opioid. So be careful, be mindful. It's personally my least favorite opioid. It has lots of side effects and probably safer off giving them a full agonist like a low dose of an oxycodone than a low or middle dose, medium-sized dose of tramadol. And like I talked about before, make sure that we're setting very clear boundaries and expectations with the patient. I'm not going to take all your pain away. We're going to help with the pain. We're only going to be on these medications for X number of days. After that, we need to come up with a different plan to help manage the pain if you're still having it. Next slide. Another situation you may see is they're a chronic pain patient, they're on chronic opioids, and now they need a benzodiazepine for an acute setting. And so this is the opioid tolerant patient plus new benzo prescription. And I'll be honest, these patients are going to be a lot more difficult to manage. It's harder to reverse a benzodiazepine. It's easier to take someone who is tolerant on a benzo, but not tolerant on an opioid and give them Narcan to reverse them. If they have too much CNS depression and they have lower respiratory rate, it's not as easy if it is the other way around. Now, if they're in the inpatient setting, you could consider flamazino, like a little 0.1, 0.2 IV. If they get over sedated from benzodiazepines that you prescribed, but there really is no naloxone equivalent flamazino that's rarely available to the public to take home. And there have been some studies that looked at prescribing benzodiazepines for whatever reason, and patients also on chronic opioids, and they did find an increase in overdose and overdose death with those patients. And so make sure that we are looking at the medication interactions and really trying to find an alternative medication instead of a benzodiazepine. Even for things like alcohol withdrawal, which you can do, these patients really should be treated in the inpatient setting because they had this chronic pain condition with their opioid use. They are by definition going to be probably a moderate risk withdrawal patient from the start. So those patients are really not appropriate to do on the outpatient setting. Next slide. Now I should really talk about benzodiazepine and opioid use disorder together. So benzodiazepine use disorder, opioid use disorder, both of these can coexist in the same patient. There are lots of different opioid mixtures that are commonly cut with different adulterates, like benzodiazepines. Probably the more common ones are going to be the fluorinated or brominated benzodiazepines, or designer benzos, or alpha-2 agonists, things like Tranq or xylazine or medetomidine. They're very commonly found within the opioid supply. And so these patients, a lot of times they'll come in and withdraw to both. And so it is safe to start medication for opioid use disorder and then also initiate some symptom triggered or potentially a benzodiazepine taper. Now, these patients are going to be more complex, and they really should be done on the inpatient setting, especially if they have use and tolerance and withdrawal to both of these. The combination of the two is something that really should be done on an inpatient setting. But if you are saying you're rounding on a patient, you need to discharge them home, and they still have a few days left of a benzodiazepine to taper them off completely, that's okay. Next slide, please. And the biggest thing here is please, please, please do not withhold medication for opioid use disorder in patients on benzodiazepines. Yes, I realize you had this conversation. They maybe kept this from you for whatever reason, maybe ashamed about it. But that's neither here nor there. We really need to focus on the immediate. And in the immediate time frame is we got to get them off of the illicit opioid, and then we can address their chronic benzodiazepine use at a later date once we get this addiction under control. And so, realistically, the ongoing risk of using an illicit opioid is going to far exceed any potential therapeutic polypharmacy. Yes, I'm aware there is a warning that mixing buprenorphine and benzodiazepines may lead to CNS and respiratory depression. I'll be honest, I've done this now to some various extents for 5 years, and I have anecdotally haven't seen an issue with it. It's there. It's something to be aware about, but the risk of them relaxing and using an illicit opioid and overdosing on that, which definitely will cause respiratory depression and failure, far exceeds the potential or theoretical risk that you may see with something like a buprenorphine, which is going to be a partial agonist, which for all intents and purposes is not going to cause respiratory depression in patients who are opioid tolerant. And like I said before, give these patients rescue naloxone either for themselves, if for whatever reason they do develop respiratory depression, but also more importantly, chances are they're going to know someone else who has opioid use disorder. And the more people that have Narcan that can give Narcan and save people, the more lives are saved. And then once you are on this medication use disorder, really to make sure that we're monitoring the PDMP for dispensing trends and that they're taking their medications as prescribed and not diverting them. Next slide. All right, so here was the first question here, poll number 1. We pull up the answers. Okay, you guys are really good. You all didn't fall for this. Go ahead and close that poll out for me. Move on to the next slide, please. Right, so this is false. So benzodiazepines alone do not cause respiratory depression. Now, when they're mixed with other things, they can cause pretty profound CNS depression, which can then lead to decreased airway protection and increased aspiration event, or it can lead to decreased upper airway soft tissue tone, which can lead to some upper respiratory obstruction. But they do not actually drop the respiratory rate in and of themselves. Next slide. True or false? I should taper my patients benzodiazepines before starting them on methadone or buprenorphine for opioid use disorder. What does the survey say? Okay, good. This is a little bit more mixed. Awesome. 60 said true. Awesome. Cool. Next slide. Yeah, this is actually probably false. Like I said before, really need to get them off of their illicit opioids onto a medication for opioid use disorder, and then we can address the benzodiazepine elephant in the room. But let's get them stable with their acute active addiction first. Awesome. Next slide. All right, now I am going to hand this over to my colleague here, Dr. Amy Vandenberg, to kind of talk about to benzo or not to benzo. That is the taper. Thank you, guys.
All right, thank you, Alek. That was a great overview and intro into this. So I'm going to start off with a few more poll questions. If we can go to the first one. So the first one is, when inheriting a new patient, which of the following regimens would most prompt you to discuss benzodiazepine tapering? So we have a 38-year-old taking alprazolam when they fly about once a month, 27-year-old taking lorazepam for catatonia, 45-year-old on clonazepam twice daily for 5 years, or a 73-year-old on lorazepam as needed, taking about 20 tablets per month. Okay, so it should be a toss-up between the last two. Obviously alprazolam every once in a while for flying is fairly low risk and doesn't need tapering. Catatonia is sort of outside the scope of what we're talking about with tapering benzodiazepines because it's a different use. But really either of the last two should be tapered. We want to look at, or at least discuss it and think about what the risks and the benefits are for those individual patients. We'll do one more poll question. And this is not when inheriting, but when initiating benzodiazepines for anxiety or insomnia, how often do you discuss expected duration of therapy with patients at the time of initiation? Is it only if they're over 65, most of the time, half the time, or 25% or less? All right, so it was a kind of a leading question. So most of the time, that's good. We got 90% with that. So we can talk about when we should be assessing risks and benefits, what those risks and benefits are, and then introducing the idea of limited duration and tapering medications in patients and some alternatives. So we can go to the next slide. One of the key points of the ASAM guidelines on benzodiazepine tapering is around this notion of ongoing risk-benefit assessment. In an ideal world, we would be doing that every 3 months for patients who are ongoing benzodiazepines. That's not realistic always, especially for medications that can have 5 refills. So 6 months may be the minimum interval. But with each new prescription or renewal, there should be some assessment of risk and benefit, as well as what do we think about the duration of medication for this individual patient. It should include review of PDMPs, not necessarily because we're concerned about misuse or multiple prescribers for an individual, but we want to make sure they didn't go to the emergency room with a broken bone and get a new prescription for opioids that we didn't know about. For patients who are taking ongoing opioids with a history of substance use disorder or other risk factors, we may want to do it more frequently than with each renewal. And then for patients over 65, because the risks start mounting, especially, we want to consider a taper. And whether that's a taper down versus a taper off may be an individual decision, but we should at least start thinking about it in patients who are over 65. Next slide. If we look at those benefits and risks, an important part is to acknowledge that there's benefits. Benzos make people feel better. If people have anxiety, their anxiety feels better. With benzos, they may have some functional improvements. They may have quality of life improvements with the medication. So we need to acknowledge that. We also need to figure out a plan on how to have those same successes without benzodiazepines if we're going to talk about tapering. But there's also risks of use. And as mentioned, these tend to start escalating in patients as they age. Our brains become more sensitive to benzodiazepines, more sensitive to oversedation. I may be more likely as I age to take other medications that can have some sedating properties. And then when I think about alcohol and substances as well in all patients, as I get older, I'm more likely to fall. I'm more likely to have cognitive impairment. I'm more likely to take more medications which may interact with my benzodiazepine. I'm more likely to develop co-occurring conditions, things like COPD or obstructive sleep apnea that increase the risk of taking these. And then again, we want to think about diversion, potential substance use disorder. Fetal harm is kind of a niche area. There's low risk of congenital abnormalities with benzodiazepines, but there is a risk of neonatal withdrawal if benzos are taken throughout pregnancy. And so we want to address that early if benzos are on board in pregnancy. We also want to acknowledge the risk of tapering. So withdrawal symptoms are scary and can be dangerous for patients, and that's where people don't want to taper off. Oftentimes patients have been tapered in the past quickly and it did not go well, so we want to try to avoid that. I mentioned the benzos are treating something, so we want to make sure that we avoid recurrence of that underlying condition. And then think about other impacts. So if I have co-occurring depression or bipolar disorder and my sleep gets disrupted with a benzodiazepine taper, I may be more likely to relapse into an episode of depression or an episode of mania in the context of bipolar disorder. There's a risk of protracted withdrawal, which I'll talk about in a minute. And then we also want to avoid rapid tapers or abruptly discontinuing because of the risk of transition to illicit use, which is going to be more dangerous. All right, next slide. As we're looking at these different risks and benefits, a couple of things to think about is how significant are the benefits? If I have somebody who had panic disorder and they were unable to leave their house because of their severe panic disorder, and now they're able to go out to the grocery store or go to work, that's a big benefit. We need to make sure that we're addressing that underlying condition before we say benzos are risky and we have to taper off. How significant are the risks? Again, as I age, those risks get higher. Also, how imminent are the risks? If I have somebody who has fallen or they're having cognitive impairment, those are pretty imminent. If I have a 25-year-old who is on chronic benzodiazepines, they haven't had issues, the risks aren't imminent, but the risks are in the future, and the risks have more to do with the risk of withdrawal and severe withdrawal as they come off of it later. I also want to think about risks and benefits of alternatives and likelihood of alternatives to work for what this benzodiazepine is treating. Okay, next slide. So as I've alluded to, we don't want to abruptly discontinue benzos in patients who are likely to be physically dependent. It doesn't take very long for patients to become physically dependent. We'll talk about that in a minute. It's important to collaborate with patients on the taper. Obviously, this varies depending on how imminent the risk is. Are we talking about somebody who's in the hospital after overuse of benzodiazepines and opioids? That's going to be a little bit different story than somebody who comes into clinic who has been on chronic stable benzos for a number of years. But let's work with them on what the plan is and how we're going to approach this taper. We want to minimize harms from use, but also minimize harms from the taper, which can include everything from withdrawal to symptom recurrence, and then this notion of protracted withdrawal. Patients are very different. So part of what we did with the guideline was a patient panel, and some people taper off benzos quite easily, and other patients have significant trouble even with small dose reductions. And so there are the extremes at either end, and we want to make sure that we are tapering in a way that's tolerable for the individual that we're treating. As mentioned, and I'll reiterate it again, we want to provide concurrent treatment for co-occurring disorders, including substance use disorders and opioid use disorder. Next slide. Who's likely to be physically dependent and experience withdrawal? Typically longer use and higher doses. So anyone who's on moderate to high doses for more than a month, taking most days a week, there's a potential for significant withdrawal. If we're looking at lower doses, 3 months or less, there's a lower risk for withdrawal, but it's still possible. And we want to be sure that we know that withdrawal is withdrawal and recurrence of symptoms, which can start looking like protracted withdrawal is something else. And so I can get somebody safely off of benzodiazepines without significant withdrawal quicker than I can get somebody off of benzodiazepines in a way that's tolerable without recurrence of symptoms. And so for this slide, I'm talking about significant withdrawal, not symptom recurrence. And so if we think about the patients who were in the case, the patient who's taking alprazolam once a month for flying is not going to experience withdrawal. They're probably not going to experience a recurrence of anxiety, even if I were to stop it. They would just be really anxious if they had to fly, versus the patient who had been taking benzodiazepines for 5 years, very high risk for withdrawal. Really important that we taper that person off. The patient who was 78, we didn't have a duration of treatment, but with age, you're also at risk for withdrawal. So we'd want to be very careful in that patient as well. Okay, next slide. This is my attempt at using AI to have a picture that helps describe what's happening. But I think to understand why we have this withdrawal and why we have this recurrence of symptoms and why maybe we even have a protracted withdrawal, we want to look at what happens in the brain when we take benzodiazepines. So we talked about benzos. Alek talked about benzos stimulating GABA. So they stimulate this calming effect, anxiolytic effect in sleep. Well, our brain likes to stay in balance. And so the balance of GABA is glutamate. If I'm the patient who's taking alprazolam for flying, when I get ready to get on a flight, I see that plane, my glutamate levels bump up some. I take the alprazolam and it evens me out by bumping up my gabapentin. If I'm not looking at a plane, I stay back in balance. And so that's why for something like that, I can take a benzodiazepine intermittently. It goes back to balance relatively quickly. What happens if I get into a few weeks to a few months, so that 1 to 3 month range of taking benzodiazepines, is as I take the benzo and I start increasing GABA activity, my brain wants to balance that and it starts bringing up glutamate activity. And so I may be at risk for withdrawal at that period because if I abruptly stop the benzodiazepine, I have too much glutamate. And it's that imbalance that's leading to withdrawal. It's that imbalance that's leading to recurrence of symptoms. So that's in that 1 to 3 month range. If I continue to take benzodiazepines long term, greater than 3 months, our patients who have been on them for years, what also happens is my brain says, hey, there's enough GABA activity. I don't actually need as many receptors to have that activity. And our brain starts making less GABA receptors. They downregulate. So now not only am I dependent on the benzo to have that GABA effect that's balancing glutamate, but now if I take that benzo away, I don't have the endogenous ability to balance that out as well. And the glutamate levels are so much higher. That's where the significant withdrawal comes from. That's where the relapse and symptoms comes from. And that's where tapering becomes important, because if I slowly decrease the the benzodiazepine dose, it's allowing the glutamate to come down slightly as well. It's allowing those GABA receptors to upregulate back to where they were initially. And the longer I've been on the benzo, the longer this process has taken, the more I've downregulated, and the longer it's going to take for that to re-regulate. So this is where the slow taper becomes really important. Next slide. If we look at protracted withdrawal, a lot of this is based on case literature. There's a few retrospective survey studies that surveyed patients who had protracted withdrawal, but as far as the incidence of this, it's not really well known. Another name for it is benzodiazepine-induced neurological dysfunction. And these are symptoms that last well past the acute taper phase. So after I've tapered somebody off of the benzodiazepine, they still have these residual symptoms. A lot of these seem like they could be due to a continued imbalance of GABA and glutamate. So things like anxiety, agitation, akathisia. Some are less clear. So things like depression and psychosis, and formication, feelings of bugs crawling on my skin. It's not as clear where it's coming from, but there are definitely temporal relationships between tapering off benzodiazepines and these things happening. So in addition to being sure to watch for withdrawal and rebound anxiety, we want to look for protracted withdrawal symptoms in patients as they're getting towards the end of the taper or are tapered off. Okay, next. How do we avoid withdrawal? How do we avoid rebound? How do we try to avoid this protracted withdrawal? Well, it's with slow tapering. And so initial dose reductions, we may be looking at on the order of 5 to 10%. That seems very small. I'm going to get to that in a minute. When I trained, we were told you could taper benzos 25% every 2 weeks and it would be fine. To avoid acute withdrawal, that would be fine. That would be actually a longer taper to avoid acute withdrawal. Avoiding withdrawal is not the same as a successful, well-tolerated taper, though. So we want to taper very small, especially with the initial dose reduction. That tends to be difficult to tolerate. That first dose reduction is hard. And at the very end of the taper, those last dose reductions can be hard as well. So we do that initial 5 to 10%. If the patient tolerates it, that's great. We can reduce it again. If they have no issues, maybe we can reduce by even more. If they don't tolerate it, maybe we need to keep them on that dose even longer. And one of the things that we want to avoid is going back up on the dose, because then we end up back on that roller coaster. So if we taper a dose and a patient has some rebound in anxiety, what we want to do is stay at that dose even longer, and not taper again until symptoms become better under control. We may consider transitioning to patients who don't have contraindications to a comparable dose of a longer acting benzo for the taper. There isn't a lot of evidence on doing this, and there's variability between benzodiazepines and what those dose equivalents are. I'll talk about that a little bit later. But if a patient is interested in it, that certainly is something that you can consider, something that's going to act longer. Typically, we're using clonazepam for that. Something like lorazepam to clonazepam may be tolerated okay. The one that seems to be most difficult to transition is alprazolam, because it has that short half-life, relatively short duration. it's basically spiking that GABA really quickly and causing even more of a roller coaster of effects between GABA and glutamate. And patients tend to have a harder time coming off of alprazolam. So if nothing else, try not to initiate it. Use other benzos to initiate. But if you do have patients on alprazolam, they may not be able to tolerate transitioning to another agent. Next slide. We've looked at risk benefits. We've decided that the risks outweigh benefits in this patient. We want to start thinking about a taper. What is the optimal time? So again, obviously, this isn't somebody who's been hospitalized with an acute complication of benzodiazepine use. This is more somebody who's getting chronic medications in the outpatient setting. Well, let's look at the current situation. Are their symptoms currently well controlled? Do we have an alternative long-term plan in place? So if this patient's on chronic benzodiazepines for something like generalized anxiety or insomnia, let's get a treatment plan in place and assess, again, the level of risk. So this is more for outpatient, relatively low imminent risk, but we consider the long-term risk too high. Then we want to say, well, is now the best time to do it? Symptoms are well controlled, but if I'm going to be moving, changing jobs, having a wedding, traveling, whatever it may be in the next 2 months, that may not be the best time to start the taper. So let's think about what's going on in the next few months and try and set basically a target time to start that. Introducing other coping strategies is really important throughout the discussion of starting a taper and when we do it. I talk to patients about things like exercise, mindfulness, progressive muscle relaxation, and starting to practice those strategies early and often because they're going to be more effective the more they're practiced. Okay, next slide. Some tips for communication, and then I'm going to go into some of the examples of how I explain this to patients. So I work primarily on the inpatient side. I've worked in the outpatient in the past. And with our inpatient program, as well as our day treatment program, we do groups once a week, inpatient every other week in the day program. And it's predominantly patients with mood and anxiety disorders. One of the number one questions that we get is around benzodiazepines and tapering from the patients. So between that and then what we've discussed with the ASAM guidelines, we do want to discuss the idea of tapering early and with each renewal, as I mentioned. The focus should be patient specific. It's hard for me to do this in a group setting, but with an individual patient, if I give them a blanket list of risks and some of them or many of them don't apply, it doesn't really hit as much. But if I say this specific thing is a risk for you to be on this medication that I'm concerned about, it's going to hit a little closer to that patient. We want to acknowledge that the benzodiazepines are effective. They work to treat anxiety, so we have to acknowledge that. Realistic expectations for alternatives are important. So I'm going to talk about some alternatives in a minute, but I've had patients say they gave me hydroxyzine and it didn't do anything. And I said, I bet it didn't do anything. It's not going to have the same effect as lorazepam. Lorazepam, I can take you from a 10 to a 2 on level of anxiety. Hydroxyzine may take you to a 6 or a 7. It's going to take the edge off, but it's not going to take it away the way that a benzodiazepine did. Sometimes I'll talk about mechanisms. So the AI figure that I showed you earlier and the balance between GABA and glutamate, if patients are able to grasp those concepts, I'll talk about that. And sometimes that's helpful. I want to make sure I focus on both immediate and long-term risks. And I'll get to that as I give you some examples in a minute. And then involving the patient, as I mentioned. Some things to avoid. And this has come from feedback that I've gotten from patients over the years in groups, but also from our patient panel for the guideline, is overt or subtle implications of misuse. And this is often unintentional. I'm not suggesting that people intentionally are accusing patients of misuse when they're not misusing medications, but even the term dependence, if we're talking about physical dependence, sometimes is misunderstood as substance dependence or addiction. So I'll talk about it in terms not of physical dependence, but your brain is used to this medication being there. As your brain chemistry changes with the medication being on board, we have to be careful with bringing it off because you'll have withdrawal symptoms. So I try not to use the word dependence. The other message that sometimes patients hear is we say, well, benzodiazepines aren't the best medication to treat anxiety. Benzodiazepines are bad in the long term for treating anxiety. Things along those lines, patients sometimes will hear, well, if benzos are bad and I'm taking benzos, I must be bad. And so it's just unintentional messages that sometimes come across with the words that we're using around them. Forcing a taper in a situation when it's not immediately necessary, you're just not going to get buy-in from the patient, obviously, and you run the risk of withdrawal symptoms or seeking other sources for benzodiazepines to treat those symptoms. And then finally, urine drug screens, notoriously poor at identifying benzodiazepines in the first place. There's a lot of false negatives. Different institutions use different assays, but they're kind of notorious for having false negatives. So they don't help us to say that patients are taking it, but there's false negatives. So it also doesn't help to say that patients have stopped taking benzodiazepines. So we just try to avoid using those because they tend to not be helpful. Next slide. So next, I'm going to give you a couple examples of some talking points that I've used with patients over the years, both with introducing the idea of short-term use, but also addressing the potential need for taper in patients who have already been on benzodiazepines. So with short-term use, I have a fairly basic version. I usually start with, yes, this medication, and oftentimes I've had patients who've had 1 or 2 doses. I said, I bet it worked for your anxiety. It made you feel less anxious quickly. But it's not going to address the underlying causes of the anxiety. It's basically covering it up. And the 2 analogies that I use, one is it's kind of like throwing a blanket over a lamp. That light bulb is still burning. It's still hot. Doesn't work as well with LED lights as the analogy, but like eventually it's going to burn through the blanket or the blanket's going to get pulled off. And that's the benzodiazepine wearing off. That anxiety is still burning bright. So I'm just covering it up. The other analogy I use is a car. So, if anxiety is your car rushing down the road with your foot on the gas, if I give you a benzodiazepine, it's basically like hitting the brakes. The engine's still revving, it's still, pushing power to the tires. As soon as the benzodiazepine wears off, that car is going to go racing down the road again. So we want to have something that dims that lamp. We want to have something that takes our foot off the gas, not something that just covers it up. And then I let them know after 2 to 4 weeks, if you're taking this consistently, you may have some rebound anxiety. Your brain's trying to counter this medication, and you may have rebound anxiety if you stop it. After a few months of taking it, we have to be really careful about tapering. There's an acute withdrawal that kind of looks like alcohol withdrawal because people are more familiar with alcohol withdrawal and what that looks like. So after a few months, you're going to experience a withdrawal that's like alcohol withdrawal if you stop abruptly. But here are some long-term strategies for your insomnia, for your anxiety that we can use. We can get them on board and then try to pull the benzodiazepine off. So our goal is short-term use. Our long-term options are X, Y, and Z. Okay, next slide. Another one that I'll use, I'm not going to go through all of this just in the interest of time, but it's very similar to the other one. I just use basically the ideas of that graphic I showed earlier with the notion that that GABA and glutamate become imbalanced, and that's what leads to the symptoms of rebound anxiety and the symptoms of withdrawal. And so this just depends on what patient's ability is to grasp those concepts. But again, acknowledge that it works and then go into alternative treatments. And depending on interest, and I'll talk about the mechanisms of the other medications that may be better as long-term options. Okay, next slide. So those are kind of, I've had 1 or 2 doses. We're thinking about starting benzodiazepines. How do we let patients know it's going to be short term? The other option is somebody's already been on this for months to years. Acknowledge that it's been helpful. Again, I work in inpatient and a day treatment program. So oftentimes I can say, I'm sure it acutely helps your anxiety, but we're dealing with chronic anxiety right now that is not well controlled. And so while it does help in the moment sometimes with the symptoms, we want to have something in place that's a better long-term plan that's going to take you off this roller coaster of benzodiazepines. In younger patients, I'll say, hey, even if maybe they're not on a roller coaster, maybe it is really effective. So I want you to be aware the longer you take this medication, the more difficult it is to eventually stop. And at some point, you're probably going to need to stop it. So to avoid that return of anxiety or insomnia, or potentially in the future a need to rapidly taper because of some sort of risk, let's start talking about what the alternatives are, what you're interested in, and think about when we're going to initiate that plan. So we can talk about medications, we can talk about cognitive behavioral therapy, some non-pharmacological interventions that you can do on your own, and then we'll talk about when we can make a small change in the dose and see how that goes. Next slide. Then for older patients, and yes, that was intentional that I said over 40 years and not over 65, but in older patients, especially if they've been on chronic benzodiazepines, oftentimes they've been on more medication trials. Because they're getting older, we want to talk about risks. So what have you been told about long-term use and risks of this medication? Sometimes patients have heard it, sometimes they're unaware of the risks of long-term use and the notion of rebound anxiety. What other medications have you tried? If somebody's been on 4 or 5, 6 other medications, I certainly don't want to offer those as alternatives. So what have your experiences been with the other medications? What have your experiences been with tapering in the past, if they've tapered before? I want to make sure that if their experiences with other medications have been negative, that it was not something about the medication that we could have done differently. Like, did we start an SSRI at a really high dose that caused anxiety when we started it? Because could we have started it differently? Were they tapered in the past, but tapered quickly? Could we taper more slowly? And then I'll say, hey, since you've been on this for so many months or years, it will need to be tapered to avoid anxiety and insomnia. And I'll say, look, the risk of continuing this as you get older, and the older the patient is, the more imminent I make this risk, is at some point you're going to have an accidental injury, a fall, you'll be confused by something, and the risk of being on this medication is going to be considered too high, and you may need to be tapered off more quickly just because of the impact it's having on your brain. So let's try and set up a strategy now to come up with some alternative plans, and again, make some small changes and start that taper now so we can do it in a way that's going to be better tolerated. All right, next slide. With co-occurring alcohol use disorder or opioid use disorder, it's sort of two different stories. With alcohol use, I talk to patients about alcohol and benzodiazepines having very similar effects on the brain. And so continuing past that point of treating acute withdrawal, continuing benzodiazepines in someone with alcohol use disorder is going to perpetuate that imbalance between GABA and glutamate. And that same imbalance between GABA and glutamate is also what causes alcohol withdrawal. And a continued imbalance after acute withdrawal is thought to contribute to some of the cravings. And so I talk about it not being the best option with a history of alcohol use disorder. With opioid use disorder, which one do we want to taper? Do you want to taper opioids or start MOUD first, or do you want to taper benzodiazepines first? Tapering both at the same time may not be well tolerated, and because there's overlap in some withdrawal symptoms, it can be difficult to determine, is it because of benzo withdrawal or opioid withdrawal? So ideally, we're doing one or the other. This may be a time to ask if patients are interested in referral to a substance use disorder specialist or peer support, especially if it's available in their area and if it's something that they're able to afford or that is covered by insurance. So this can be a little trickier, but we want to acknowledge, what role benzos have with both alcohol and opioids, and they're a little bit different. So next slide. I've mentioned a few times getting non-pharmacological interventions underway before we start the taper. These are options that I give to patients. I say there's some things you can do on your own. There's some things that you're going to probably need referral for on your own. This is not an all-inclusive list, but things like stretching, yoga, meditation, exercise, breathing exercises, progressive muscle relaxation. These things are free. You can do them whenever you want. They're effective. They also have benefits on pain and mood disorders, which are commonly co-occurring with anxiety and benzo use. They have long-lasting benefits, especially if you continue to practice these things. There's other benefits like cardiovascular benefits to these options. I do push that they have to be practiced routinely. If I do things like mindfulness or breathing exercises once a month, they're not as effective if I have to think back to where do I start? Which muscle group do I start with progressive muscle relaxation? If I have to remember, wait, how many seconds do I inhale versus hold it or exhale? That's less effective. So you want to do these things until it becomes almost muscle memory, where you just go into it and do it. And it's going to decrease anxiety overall. It's going to improve mood overall. So the cons are it requires some time, effort. The benefits aren't immediate. The longer you do it, the better these things work. And if I have somebody who has acute anxiety, they're in acute crisis, it's not really a great time to start these things. It can actually increase anxiety and be overwhelming for patients. But good things to start. I'll talk about medications. When we start alternative medications, they might get you 60 to 70% of the way there in getting your anxiety under control. These things are going to give you another 5 to 10% improvement in your symptoms. So these aren't going to do everything, but they're going to help the medications do their job. Cognitive behavioral therapy and CBTI, specifically for insomnia, consistently have positive evidence as good or better than medications. And in a lot of cases, the benefits persist even after somebody does an acute course of CBT. The benefits persist after that. The issues with it is limited access, cost and insurance limitations, and whether or not patients have the time and ability to get off work and get to appointments and do that. Virtual CBT has increased access. There still are issues of cost and time commitment, but it does make it a little bit more feasible. Okay, next slide. As far as alternative medications, I mentioned providing realistic expectations. I talked about hydroxyzine earlier. It's not going to do the same thing as benzodiazepines. Propranolol really is only beneficial for physical symptoms of anxiety or situational anxiety, like giving presentations, but it's not going to help overall things like generalized anxiety or panic disorder. Gabapentin or pregabalin may be used. Gabapentin itself has a ceiling on absorption. It's actually impossible to take too much gabapentin. It just goes through your GI tract. On their own, they're not necessarily my go-to, but especially if somebody has neuropathic pain, I like trying these because you can hit the pain and anxiety with one thing. My analogy for patients with gabapentin, because it actually works by decreasing glutamate, it's kind of like taking your foot off the gas or turning a dimmer switch on a lamp versus slamming on the brake. So it's a little more subtle. I do get concerned about peripheral edema, which is an under-recognized adverse effect of these medications. We want to watch for that, but that may be an alternative. And then with antidepressants, this is going to be our go-to for all the anxiety disorders, unless patients have contraindications, which are fairly rare. But they're going to take 8 to 12 weeks to have full effect. And so I don't want to start tapering a benzo while starting an antidepressant. I want to get the antidepressant on board for at least a month to 6 weeks to see that it's tolerated well before I start with the initial taper. Okay, next slide. So let me come back to this. Yes, I said 5 to 10%. I acknowledge that seems difficult to operationalize and is a very small amount. But it is going to be better tolerated by your patients. So I have an example here for how you'd operationalize that. Say we have a patient taking lorazepam 1 milligram 3 times daily. It is unreasonable for me to change an individual dose. I can't give 0.95 milligrams out of a 1 milligram tablet unless I go to a compounding pharmacy and come up with a liquid. Some patients need that, but that's going to be the exception to the rule. What I'm going to look at is daily dose, weekly dose, or monthly dose and see if I can go from there. And this is going to depend somewhat on patient preference and their ability to do these things. But if I have somebody who's on, 3 times a day, their total dose is 3 milligrams, I can get them over to 0.5 milligram tablets and have them take 2 tablets in the morning, 1.5 in the afternoon, and 2 at night and achieve that 5 to 10% reduction. If that doesn't sound like a good option, I can go to weekly or monthly doses. And basically, I'm cutting a number of tablets out. So instead of 21 1 milligram tablets over a week, I'm going to give 19. And then I can leave it up to the patient. Or if they want, I can tell them when to do it, but I can leave it up to the patient and say, hey, if you're having a good day and your anxiety seems really well controlled, just take a half tablet or don't take a tablet for your midday dose. Just skip that dose. If that's tolerated well, the next prescription, I can cut it down to 18 or 17. So I want to cut that percentage by my current dose. So I'm not going to cut by 2 tablets every time. And that this seems to be better tolerated. Not a lot of studies on this, but anecdotally, what we came up with the taper guideline was this being better tolerated by patients and a way to achieve this real small dose reduction. If somebody cuts 2 tablets out and they say, I have no issues with rebound, no issues with withdrawal, you can cut more, but that first reduction, you want to make it small. Okay, next slide. I know I'm running out of time. Couple notes on benzodiazepine dose equivalents. You'll notice in yellow on this chart, these equivalents are different. I've got the VA Department of Defense guidelines versus the Ashton manual. Important to know where these equivalents came from. That's why I have it in quotes. This is based on subjective patient report. The initial equivalents came out of a study of patients presenting for treatment of benzodiazepine use disorder, basically whatever they were on at home. They gave them escalating doses of diazepam until they felt that they had a similar response to their home benzodiazepine. They averaged those out, and that's where the dose equivalents came from. There's 3 or 4 other studies that also have variable responses, and that's partially because these are subjective responses. But there's also differences between these medications that Alek alluded to. So all these at the top are CYP substrates. So if you have patients who are on medications that inhibit or induce metabolism, you're going to see changes in effect of these medications, where something like lorazepam is less susceptible to that. Point being, take these with a grain of salt a little bit. Somebody may not fit into the categories of these for a conversion. Some patients may need higher doses or lower doses if you're converting between, and that's where it makes it tricky to convert for tapers. All right, next slide. And I'll stop. Okay, last one. So as far as goals and duration, it depends on the patient. The goal may be fully tapering off. The goal may be tapering to a minimum effective dose. So if I go back to the 78-year-old who's taking 20 tablets of lorazepam per month, what was their history? Did they used to be on 2 milligrams 3 times a day, and now we've gotten to a minimum effective dose and they're tolerating it? That may be our risk assessment for that patient. Lower doses are still going to mitigate risks. And so if we can get the dose lower, that may be our best option. Ideally, we can taper off. As far as duration of taper, you want to think in terms of months rather than weeks for anybody with chronic use, because we're not going to be able to taper off over weeks. It's going to be months in most cases. And just to reiterate, to initiate and titrate antidepressant medications prior to the taper, if that's your alternative plan, because we want to get that medication on board and working before we start the taper. All right. With that, I think we are to questions.
Thank you, Dr. Vandenberg and Dr. Adkins. Really great talk. We're going to open up to questions now. You can put those in the Q&A. We will read them off and get answers from our speakers today. While we're waiting for the attendees, maybe I'll kick off with a question. What's the worst thing you've seen happen with a taper with a patient? Could you give an example?
My worst case, it happened during fellowship. And I'll put a caveat to this patient was on max dose of baclofen. So 20, actually more than max dose. So this patient was a 20 milligrams QID baclofen plus a few milligrams a day Xanax, Prazlam, plus I think it was 2 or 4 milligrams of lorazepam throughout the day as well. And every single time we try to come down on any of these medications, the patient went into fluoride withdrawal, seized, aspirated, would go into status intermittently, and have to be intubated. Then we would do a propofol wean them off, have to reintroduce them back onto certain amounts of benzodiazepines to get the propofol down, and then we try to restart the taper again, and then over and over and over again. So eventually, we kind of had to put them on phenobarbital. We had to do a phenobarbital load, and then we were able to taper the phenobarbital down to I think like 67.5 or whatever the low dose of the oral is off the top of my head here, twice a day. And that is about where we could get them until we could get them through their acute rehab stint. And then we handed it over to the outpatient setting to finish off the taper, I think, over several months after that. So that is the most extreme GABAergic tapering that I've been a part of.
Yeah, I don't think I can top that for a taper. But as far as I'll say, as far as risk benefit assessment gone wrong, this was years ago. I had a patient who was in their mid 70s who had been on diazepam for like decades and had basically saturated his adipose tissue with diazepam and was just came in intoxicated on benzodiazepines. And so his taper involved just stopping it and letting it eventually leach out of his adipose tissue because it's something that we teach people in theory can happen, but it's the only time I saw it happen. And we investigated every other possibility of his symptoms, and it was like, no, he's just a big sponge of diazepam at this point.
Kind of keeping on the lines of diazepam, Dr. Atkins, one of the things you said was, I think the two that we see most often in practice are probably lorazepam and diazepam. And Dr. Vandenberg talking about the tapering patients and operationalizing a really small change in lorazepam dosing. Have you ever considered, or do you routinely switch patients to something like a diazepam where potency changes may be beneficial to you, or do you find it more beneficial to keep what the patient has and taper that?
If they tolerate diazepam, I would prefer that. Again, I will coming from I work from the acute setting more, and from a toxicology standpoint, so I always think about worst case scenario, and idealistically, I want to get them to a point where whatever I'm prescribing them, if they're taking it all at once, it won't kill them, because that's kind of my patient population, unfortunately. So I do prefer diazepam. I actually like the long half-life on it. It makes me feel more comfortable that I can prescribe like lower doses, and like Dr. Vandenberg state, like they are not going to feel good, but at the very least, from a physiologic safe standpoint, we can take it down a little faster, or we can be maybe a little bit more aggressive with that benzo taper if need be. So I'm very biased in that diazepam is hashtag number one bay in my book, and alprazolam is the crazy X that I never want to see again.
Yeah, I would agree. For if we're talking about acute withdrawal, we're pulling off benzos because there is an imminent risk and we need to taper it off from a safety standpoint. We're treating alcohol withdrawal. I like diazepam in that area. If it's something where I'm talking about an outpatient sort of prolonged taper, you do have to be cautious that diazepam has a long half-life, but it does redistribute quickly and can have a short duration. And so sometimes if we tell people it lasts a long time, they get confused if 4 hours or 6 hours after the dose, they've got some rebound anxiety or recurrence.
So one of the challenges I think that a lot of providers deal with is that conversion, right? So a cleaner way that I think people have understood are converting between two opioids, right? And that data comes from you're on morphine, you get a pain score of a 6. We try you on oxycodone, your pain score is 6. They're equal analgesic. Dr. Vandenberg, I was hoping you could go more into some of that data that data in quotation marks there about transitioning and how to help people actually make those transitions should they want to switch to a diazepam as an example.
Yeah. So I think if you want to switch the tables, whichever one you use, because they're similar, but they're different. There's variability between them. Use them as a starting point, and then you expect that you may need to adjust the dose. So if you're going to convert somebody over to diazepam, convert them over and get them to a dose that is effective for them, and then taper from there. Don't convert them over at a dose that may be considered a small taper, because then it's unclear if they have symptom exacerbation. Is it because the conversion wasn't quite right for that patient, or is it because the taper that we introduced was too much? So trying to get them, need to get them stable on that alternative med, and then try to taper from there.
How long do you typically take for a patient to switch between benzodiazepines?
On the inpatient side, we may do it over a couple days. On the outpatient side, I would get them over to what you may consider an equivalent dose. Maybe give them, 7 to 10 extra tablets that they can take as needed to augment that. And then after 2 weeks, say, does this seem to be pretty similar? If so, we're going to taper from there.
Dr. Atkins, anything to add about that discussion?
No, I think that's good. I think the one benzo that I have tried over and over again to switch over that I've failed every single time would be alprazolam. And if someone is on alprazolam, I have just, maybe it's not patient enough, but I've never been successful. So alprazolam is just the one, like, all right, well, that I won't try to switch them. I could see switching from lorazepam to diazepam.
Yeah.
Maybe clonazepam clonazepam to diazepam. Although I probably would just have the patient stick with clonazepam. I feel like it's a little less painful and more smoother.
Mm-hmm.
But yeah, alprazolam is the one that I have given up even trying to do a benzo switch before tapering down and just gritting my teeth as I slowly try to come up with a plan where the patient's willing to adhere to it and it's safe.
The takeaway is don't prescribe alprazolam if patients have never been on it before. It's going to go poorly at some point.
Great advice. So both of you are specialists and come from backgrounds that are highly resourced, I'll say, knowing where you two practice. What's some advice you may have for clinics either in rural areas or have less access to kind of the specialties that you two are involved in that are taking care of patients on benzos or before they start a benzo? What's advice that they can take away from?
This is where I'll put a plug in for the Poison Control Center, 1-800-222-1222. So I know a lot of people think about the Poison Control Center for acute ingestions and intoxications, but we do a lot of work with the public on a lot of different revenues. And a lot of your toxicologists have a special interest or are board certified in addiction medicine as well. I'm like 98% sure that Andy King, who is your all's toxicologist in charge of the Michigan Poison Center, he is addiction board certified, if I remember correctly. So there's always a toxicologist on 24/7. Most of us have a decent understanding of benzodiazepines and opioid use disorder and opioids and how to help you come up with a starting point if you are stuck. Most of our poison control centers are also staffed by pharmacists and nurses who are specialized in this as well. So between all of us, we can usually help you piece something together if you need something kind of around the clock and you can't get a hold of anyone.
Yeah, I mean, and I would put in a plug for ASAM, and I've got a link to the guidelines in the slides. I hit the tip of the iceberg on the information that's available in those guidelines. There's a lot of additional case examples that give examples of how to taper off, options for alternative treatments. There's a lot of resources in that guideline around alternative treatments, not only for anxiety, but also for insomnia, which I didn't touch on as much today, and strategies to transition. There's more information about patients with co-occurring opioid use disorders and strategies there. Because, yeah, there are a lot of areas where these things just aren't readily available in the community, but give some options. And I think for things like CBT, the virtual CBT has been a huge thing in expanding access to that where it may not be available. So.
And I would just like to plug that the ASAM clinical practice guidelines, they are very easy and to the point with appropriate literature in them. So if you need a quick read, or if you're a little more on the ADD side of things and get concerned, or you may feel overwhelmed, these resources on there are very approachable.
And you don't need a Xanax to get through them is kind of what I'm understanding. Great. Well, thank you both for the presentation and answering the questions. It was a really wonderful talk. I learned a lot. And Jill, if you could bring the slides back up, we'll close out the talk. So thank you, everyone. Dr. Vandenberg, Dr. Adkins, really great presentation. And everybody that joined today, you'll be able to find the recording for this webinar on our website in the coming weeks. We also encourage you to visit the Safer Prescribing Toolkit, where you can find evidence-based information on opioid prescribing, benzodiazepine prescribing. Coming soon, we will have a toolkit on benzodiazepines for your reference as well. You will receive email links with this QR code and the couple you'll see shortly following the webinar. Next slide. To claim CME, please scan the QR code on your screen. And again, that'll be emailed to you shortly following the presentation. The follow-up email will also contain a survey. If you could fill those out, that would be really wonderful. We do our best to read all of the responses and really greatly appreciate your feedback. Next slide. And one last shameless plug here, but this is the next webinar that's coming. We hope that you can join us. It's in about 2 weeks, and it's on the topic of nursing and opioids, providing pain care and preventing overdose. You can scan that QR code as well for more information. This will also be in the follow-up email and is also on the website. Thank you, everybody. I hope you learned as much as I did.